Thank you. Thank you. Hello, good morning, everybody. This is a meeting of NHS Lincolnshire ICE Integrated Care Board's Primary Care Committee meeting in public. I'm Jerry Matsawley. I'm a non-executive director on the Integrated Care Board for Lincolnshire, and I chair this meeting. There's an agenda that's been published for today's business. For colleagues on the committee, if you would kindly keep your cameras off until you need to come in, that would be very helpful. Otherwise, by all means, use the facility within Microsoft Teams to put your hand up if you want to come in, and I'll draw you in accordingly. So without further ado, I'll return to the agenda, and item 1 is our usual apologies for absence. I've got a note of Jackie Bunce, Wendy Martin, and Professor Sir Jonathan Van Tam. Are there any other apologies that I need to note for the minutes today?
Hi Jerry, yes, Sandra Williamson, but Sarah Starbuck is here today representing Sandra.
Thank you very much indeed, Sarah. So we'll note that as well. And in the light of the agenda, it's important that we record if there are any pecuniary or non-pecuniary interests or any conflicts of interest relating to the agenda. So if any colleagues want to do that. No. Okay, we'll take it. Therefore, there's no conflicts of interest or pecuniary or non-pecuniary interests. And though I was absent at the, I was present at the meeting on the 15th of June. Are there any, given it's a wee while ago now when that meeting took place, many colleagues around the table will be new to this because it was a meeting of, during the under the remit of the CCG before the ICB came in at the beginning of July. Our colleagues nonetheless happy to approve the minutes of the meeting of the CCG's Primary Care Committee on the 15th of June. I'll look for any people's indicating that they have reservations about those minutes. So I'll take those minutes therefore as approved. I think in the light of the time between June and now, I suggest that we move straight to item 5 and pick up a progress report relating to a number of ongoing items, one relating to the sidings, one relating to Spalding, and I'll turn to my colleague Nick Blake to introduce this particular item. Nick.
Thank you, Jerry. I'm Nick Blake. I am Acting Programme Director for Integrated Primary Care and Communities for the Integrated Care Board. In terms of the update on the sidings, following a procurement exercise, the contract was awarded to take on provision of general practice services, the sidings practice, and that was awarded to a company called Omnis on the 1st of July. Following on from that, there was a process to go through due diligence and to review contract mobilisation with the previous provider, which was Lincolnshire Community Health Services, and the new incoming provider Omnis, to review information provided by LCHS around staffing and just to review mobilisation plans with a view for service delivery to start from the 1st of September with the new provider. That all went reasonably smoothly. There were some issues in terms of some of clarification of information and some additional costs which were agreed as a result of some of the information LCHS provided over the due diligence process. But service restarted from the 1st of September, and there are fortnightly meetings between the ICB Primary Care Commissioning team and Omnis, just reviewing delivery and reviewing mobilisation plans for additional services, with a final mobilisation plan due from Omnis at the end of this month on the 29th of October, which will cover some additional services they're planning to roll out to that patient population. One thing flagged to the committee and one thing that's come up following mobilisation of the contract is some additional staff costs that have become apparent to Omnis in relation to salaries for staff and staff that didn't appear on the initial information provided by LCHS and following the due diligence process. So there's those additional staff costs equate to around, and this is an estimate, so just to clarify that the final costs are being confirmed, but the estimate is around £100,000 per year additional costs, which are being reviewed but have been approved by the ICB to support Omnis in terms of them discharging their legal requirements under TUP and taking on the contract. So I'll pause there. That's the key points, but very happy to take any questions or comments from the committee. Thank you.
Thank you very much indeed, Nick. Are there any observations or questions from the committee relating to sidings? I know there's obviously an issue with this extra cost, Nick, and I think there's probably needs to be some reflections upon the identification of extra costs, which may well need to be picked up in other parts of our organisation, rather than just accepting them. It does require at least some further investigation so that our understanding of what the costs are of a service are known as early as possible in any process. Any other observations that colleagues want to make about sidings? I just said at the beginning, for members of the public who might be listening and watching our proceedings, if you do have any questions that you want to raise, there is a question and answer facility in the Teams software arrangements. You'll see it at the top of your screen. If you want to insert a question, we don't commit ourselves to answer that question in the course of the meeting, but if you provide contact details, we do commit to providing an answer after the meeting. So thank you. Is there anything else that any colleagues want to raise, anything relating to sidings? I'll bring my colleague Julie Pomeroy in. Julie.
Thank you. Just picking up those additional costs, it says 100,000 plus additional locum costs to be confirmed. Have you got a view of what that likely cost is?
Not currently, Julie. We're just reviewing that with Omnis, and that will be part of the report at the end of the month. So that's ongoing work.
Thank you, Julie. If there are no other questions or observations on sidings, we'll note the position relating to sidings and Omnis. Do you want to introduce the issue relating to Spalding and any other colleagues that you want to draw in on this particular conversation?
Yes, thank you, Jerry. I'm going to hand over to Shona Brewster and Kevin Gibson just to run through the expression of interest process for Spalding, but also the outcome of the patient engagement, if I may.
Thank you. Shona, again, if you kindly introduce yourself as you come in, that would be helpful for any members of the public watching and listening.
Thank you, Jerry and Nick. Yeah, Shona Brewster, I'm Head of Transformation in the South West locality and Primary Care Commissioning Ops and Delivery, and I have been the lead for the managed list dispersal process with regards to Spalding GP surgery. In terms of the expressions of interest process, that is still going through due process, so we're not in a position to update on that today, but we should be able to put some communications out into the public domain within the next 2 weeks. So therefore this item will be focused on the outcome of the engagement process with the public and other stakeholders. So I will hand over to my colleague Kevin Gibson to do that element of this item. Thank you.
Yes, good morning everyone. My name is Kevin Gibson. I'm the Communication Engagement Lead for Primary Care at the ICB. here to present the stakeholder engagement report relating to the Spalding GP surgery patient list dispersal. I think before I go into the report, which I'll assume has been read, it's quite a detailed report. I just want to give thanks really to all of the team that were involved in the engagement exercise throughout July and September this year. It was a really well executed exercise and a real team effort. I think it's really worth acknowledging that before I go into the report. So what I'll do is, rather than go through the report, I just want to kind of summarise some of the key themes that we received throughout the engagement exercise, which was a mixture of public meetings and a survey that was shared with patients. I think for me, one of the kind of the biggest themes that came out was just a real kind of understanding around the closure itself, or the patient list dispersal itself, and the rationale behind that, given that the surgery, a lot of patients from the surgery had moved across several years previous, so there was a lot of queries and questions around the actual process itself. So we did spend a lot of time talking to patients and really kind of explaining the detail around the list dispersal and the closure as well, and the process that we had to go through. Clearly, access was quite a key theme throughout the engagement events as well. People wanting to understand where they were going to be moved to, but also ensuring that continuity of care and quality were kind of retained, or certainly the same experience as what they were currently getting within Spalding GP surgery. Within that, transport and travel, so people were quite keen to understand the location and ensuring that it was that they would be moved to a practice that was accessible via public transport as well. There was also quite a lot of feedback relating to some of the neighbouring GP practices as well within the area. Some of the patients currently registered at Spalding GP surgery had previously been patients at some of the other surgeries in the area and had moved across. So there was a few concerns around whether those surgeries would be able to cope with the additional patients, but also previous experiences of what the patients had received at some of those practices also being a bit of a concern as well. As I mentioned, around the location, there was certainly a lot of feedback ensuring that the location of the service that they would receive was within the Spalding area, and there was also talk of the former surgery to the west of Spalding and whether that could be utilised in the future as well, and what the plans were around that, as well as some additional new services. We had quite a few suggestions on how we could perhaps improve services within the Spalding areas as well, given the kind of population growth over the coming years. So we had some really good suggestions around new services as well. There was a huge amount of praise for the staff at Spalding GP surgery and the service that the patients currently received. And I think, like I mentioned previously, I think the patients wanted that reassurance that wherever they went, that they would get a similar service, and the continuity of the care and the quality wouldn't deteriorate as a result of the move as well. And then lastly, again, just on the population growth, there was a lot of discussions around the new housing in the area and what work was happening with the local developers in terms of ensuring services are fit for purpose, but also take into consideration the population growth in the area of Spalding as well. So quite a lot of key themes that came out, and they certainly were considered and influenced some of the criteria within the expression of interest process. So happy to take any questions, comments.
Thank you very much indeed, Kevin. So are there any questions relating to the stakeholder engagement work that Kevin's referred to and is included as a paper for item 5B? It's clearly a very comprehensive piece of work, Kevin, and can I concur with your thoughts? Great thanks to yourself and the team concerned for the work they've done with the people of Spalding in respect of their thoughts around the position that we effectively find ourselves in. So are there any questions relating to the stakeholder report from any colleagues around the table? Virtual table? No? If not, thank you very much indeed, Kevin. We'll note, we're asked to note that particular very comprehensive report. In terms of the direction of travel, is there anything that we can say about the next stage of this work? Nick, do I return to you or to another colleague?
I think Shona is probably the person to pull back in.
Thanks, Shona. Shona, just in terms of the next period of time, what can we expect to be happening in the next period of time?
Yes, thanks, Jerry. So at the minute, we're just going through the due diligence process attached to the expressions of interest, which closed formally on Friday afternoon. So we are just considering all of that in terms of evaluation. We hope to be able to communicate out to the public within 2 weeks on the outcome of that process. And therefore, the intention would be to do the actual list dispersal in the month of November, recognising that there may be some individual conversations that need to take place in terms of the commitment that we gave on those engagement events in terms of any particular concerns with that process. So that's where we are at the minute. We hope to be able to put a press release out in the next couple of weeks, and then it will be the actual operational task of the list, which we have to involve NHS England in terms of that process. We will be writing to each individual household on the outcome of this process and giving further information on what will happen next. And we will communicate through a number of other routes, our website, social media, and via the press in terms of the support and getting that message out there. So that's where we are at the minute. I'm happy to take any questions. Thank you.
Thank you very much indeed, Shona. So again, I think you've given a very concise bit about what the next stage looks like. Are there any questions from colleagues that arise from this, accepting that this is a very unsettling time for the people in the Spalding area? Are there any questions that colleagues want to pursue in relation to the next stage? No. In which case, thank you very much indeed, Shona and Kevin, for giving us an update on where we are with Spalding. We look forward to a further report at another of our committee meetings in due course. If it's okay, then I'll move to item 6, which is to receive an update in relation to enhanced access. Papers attached with the agenda for today. I'll turn to my colleague Sarah Starbuck. Sarah.
Thanks, Jerry. Hi, I'm Sarah Starbuck, Head of Transformation and Delivery for the East locality, but also Primary Care Commissioning Ops and Delivery. So it was to provide an update in relation to the enhanced access provision within Lincolnshire, which came into effect from the 1st of October this year. This is a amendment to the existing provision we had in place via extended hours and extended access that was provided within primary care. All PCNs are now required to provide an enhanced access service. There are network standard hours in relation to this, which is Monday to Friday, 6:30 till 8 p.m. and 9 till 5 on a Saturday. You'll see from the paper that we have provision within all of the PCN footprints, and that's mobilised from the 1st of October. So that gives a consistent offer for patients to be able to book into primary medical services. We do have a number of different models, as you'll see from the paper. Some of them are rotational models, some of them are hub-based. So it does build on the existing arrangements that have been in place for several years, but we have reviewed and reflected on the arrangements that are in place and tried to improve and extend access where there is a requirement to do so. Patient engagement was undertaken with the PCN populations. And we've tried to ensure we have an appropriate level of provision to meet patient needs. Where access was provided outside the network standard hours, so that's in perhaps an early morning session for access, that's been maintained where there's been good uptake and good utilisation from patients. So we've done a blended approach to try and take into account the requirements nationally, because this is a national requirement under the network contract DES for primary care networks, but also to make sure we've got that local flexibility and that local need reflected within that. I think the paper will give you an overview in terms of the provision at practice and primary care network level, but I'm happy to take any comments or questions.
Thank you very much indeed, Sarah. So it is a very clear paper, and can I'm sure express thanks to the committee, to colleagues, both yourself and your colleagues in your team, and also to colleagues in general practice and PCNs to bring these new arrangements into clarity and ready for implementation. So thank you very much indeed. Are there any questions? I think it's a fairly clear paper in what's going to be happening in the next period, but are there any questions that colleagues have relating to enhanced arrangements that are being introduced? If not, thank you very much indeed, Sarah, for the work and for the report. I'll move us therefore to agenda item 7. Again, returning to my colleague Nick Blake for an update on the primary care programme. Nick.
Thank you, Jerry. So the paper sets out at a high level the primary care programme of work, and just to clarify, that relates to pieces of work that are time limited, so it doesn't cover things that we'd refer to as business as usual commissioning work. An example of that would be the work that Sarah's just described in relation to enhanced access and that transfer from practices and federations to primary care networks. The paper sets out programme governance. There's been a slight change to that to introduce the integrated care board and the systems new investment panel processes. So where investments required, projects will be reviewed by the ICB senior managers operational delivery group, and then potentially a business case developed to go to the investment panel for approval. So again, we've slightly altered the governance process for the programme, but the key point is that the primary care communities and social value steering group effectively acts as the programme board for this programme of work and oversees it on a day-to-day basis, and will escalate any issues to the primary care commissioning committee as required. In terms of the programme itself, there's a table in the paper which sets out the programme work streams, and all of these work streams are made up of a number of projects. As you can see, most are RAG rated green at the moment. In terms of delivery, the one that's RAG rated red relates to transitional bed reviews and reviewing the medical requirements, so the primary care GP input to support patients within those beds. So that has been delayed, unfortunately. And we're taking a slightly different approach to delivering that piece of work now and engaging through the Enhanced Health and Care Homes Board to really drive that forward. In terms of the other pieces of work, they're all broadly on track and no significant issues to escalate. One thing I did want to flag to the committee is the programme at the moment is based on the programme that we developed last year. with the transfer to the Integrated Care Board, the Directorate's scope of work has broadened significantly. So we'll be bringing in new work streams, particularly around long-term conditions, frailty, palliative end-of-life projects. What we will also be doing is linking in with the wider ICB programmes of work. So, for example, population health management, health inequalities and personalisation, to make sure that there are, and mental health and learning disabilities and autism, to make sure there are the site and a view between the programmes of where projects have interdependencies or where they affect each other, so we can manage that. There will be a change to the work streams and the structure of the programme over the next month, so this will look slightly different when it comes back to the committee in future. I think those were the key points I wanted to raise. I'm very happy to take any questions or comments from the committee, though.
Thank you very much indeed, Nick. It's just, for me, it's just a little bit of what's at the back of some of these, and I don't want the committee to get into the over detail about it. But if I took, for example, the work stream around people, which it says is green and talks about recruitment and retention and so on, we know historically this is such a significant issue. Both around the country, but in particular inside Lincolnshire. So it's be interesting to have at least a high level of understanding about what does green give us assurance on. So if it's something around increasing the number of people in primary care, increasing the roles and so on, reducing people leaving primary care and so on, it would be helpful to have at least some sense for assurance purposes about what does green mean or what does amber mean and so on. But notwithstanding that, colleague Julie Pomeroy, you want to come in?
Yes, thank you, Jerry. I agree with you, Jerry. It would be, I think, very helpful to have a better understanding of what each of those programmes are and what they're trying to deliver. And I think that's particularly true where you've got red ragged ones as well, so that we understand what's causing the issue, the likely impact of that, and what we're doing about it. So, yeah, a bit more detail so we understand what's likely to happen for all of them, and then perhaps a focus on things that are off, not on track would be helpful.
Okay. Thank you very much, Julie. Yes, thank you. So again, Nick, if we could perhaps have a look for the next reporting session, if we might try and say if the purpose of the committee is to provide some assurance, then what information do we need to be able to do that? And I'm again happy to work alongside you and other colleagues to help frame the committee's reports in that regard.
Thank you.
Are there any other questions relating to the programme update? If not, thank you. Can we just turn to winter planning? I think we're returning to your good self, Shona, in respect of our winter plan.
Yeah, thank you, Jerry. So there is a paper within the pack that summarises the current position in terms of winter. It gives a bit of an update in terms of the national publications that have come out so far. We know that winter plan happens every year. It has the constraints around non-recurrent funding attached to it, and often comes out very late in the year in terms of any funding that's attached to it. It's a very different feel this year, in that it has a high level system approach with a focus on the urgent and emergency care. There is a role for primary care, which was highlighted within the letter that came out on the 26th of September. And the key actions that were within that are highlighted in this paper. So rapidly assessing the needs of practices and primary care networks, and building on the local knowledge and identifying practical and supportive interventions to boost resilience and patient access, and priority given to where it's most needed. We are liaising with our PCNs and practices in terms of what initiatives might work for them. We know that it isn't a one-size solution for Lincolnshire. It is very much dependent on the demography and the geography of individual practices within PCN footprints as to what initiatives might work for them, which might not necessarily work in a different part of the county. There's some immediate changes to the network days that are being implemented through contract variation, and then there's the bureaucracy in terms of the primary and secondary care interface, which we do struggle with all year round. There's a lot of annexes to the key publications, and some of the points that we are focused on are highlighted there. The urgent and emergency care team lead in terms of the system winter planning, and they will do the necessary reporting to the regulators in terms of the board assurance framework. There's some detail there in terms of the primary care plan and what we're trying to achieve with some of the conversations that we've had quite early on. A lot of complexity linked to the different strands with winter planning across the system, and there is a number of barriers to implementation around capacity, available workforce, primary care fragility, and the expected impact from influenza and COVID infections. But we do know that the vaccination programmes for both of those are well underway and are very successful in Lincolnshire, and have been for quite a while in terms of both flu performance and uptake, and more recently the COVID vaccination programme. So there's a little bit of detail in terms of the bullet points on what we're focusing on at the minute, and this is work in progress, so we're quite early on in the stage of developing some of those plans more robustly. There's a number of risks that are identified that I've already touched upon, and then the finance and resource implications are another added complexity, as we don't just have one single pot of money that's going to flow down into primary care for winter this year. The appendix that was attached goes into some of this in a little bit more detail. The board assurance framework is very much focused around aligning demand and capacity, and you can see that on that tab, those specific actions that are linked to primary care. A lot of them I've touched on already, but some of them is around cloud-based telephony in general practice, and improving that, and we're currently scoping what cloud-based telephony we have currently, and then there's some more specific work streams around workforce and communications. It has been touched on about the importance of using data, and we are in the process of implementing an initiative that is called Shrewd Resilience. This is a collaboration between NHS England, the AHSN network, and the Innovation Accelerator, and it is just to summarise, a powerful real-time digital solution that provides simple visibility of whole system data. It empowers health and social care systems to make the most of their data, enabling the provision of safer, more effective care with improved patient flow and greater staff satisfaction. That system has just been procured for Lincolnshire, and we're moving into an 8-week mobilisation period, and we are hopeful that that will be live in December. So we know the importance of data. And then just quickly to touch on in terms of some of the other work streams in the system around capacity and demand is the issues that primary care have with discharges that are poor in quality in terms of information, and we know that as part of the 100-day programme, failed discharges are being reviewed in terms of harm, and that is a piece of work that's been undertaken by the system in terms of you know, if the information was improved for discharges, then it would create capacity within primary care, because a lot of time is spent chasing the information that's either missing from the discharge documentation, or the discharge documentation hasn't arrived at all. So that's another piece of work linked to winter. We're also looking at risk stratification, so that we are cited on those that are most at risk of admission to hospital, so that care can be put in proactively, and that will be done through various routes, neighbourhood teams, care coordinators, etc. I'll pause there. I can't see, obviously, if there's any questions, but I'm happy to take any questions. That is quite a whistle-stop tour. It's quite an intricate programme with lots of strands to it. So I've really only scratched the surface with that overview.
Thank you very much indeed, Shona. I think it might be helpful just to understand how the primary care winter plan connects to other sectors into plan. So obviously the hospitals have got a winter plan. I imagine that our colleagues in social care have a winter plan. So without going into the detail of their winter plans, how is all the various aspects of the winter plans aligned as best as we can across Lincolnshire? What's the mechanism to sense check that we're not missing something or duplicating something in terms of overall system-based winter planning for Lincolnshire? Could you or any other colleague make a comment on that?
Yeah, I can, Jerry, thank you. So the urgent and emergency care team within the ICB are the coordinating function for the whole system plan. So all our provider organisations, including adult social care, and we have a weekly system oversight group that convenes on a Tuesday with all those system partners to discuss the progress of winter plan, the risks and issues that are emerging, and that happens every week on a Tuesday.
Thank you very much indeed, Sharon. That's really helpful to see the way in which the primary care plan is nested within a bigger plan. So given the fact and taking the report in its detail, but as you say, you scratched over the surface of it in terms of what goes behind it, are there any other questions from colleagues relating to the primary care plan as regards winter planning this year? And we've no doubt winter will be as difficult as previous winters, and great work being done on the vaccination programme, both for COVID boosters and flu, as has been remarked. Is there any other questions that colleagues want to raise around the winter plan? No? In which case, thank you very much indeed, Shona, for the report. Should we just take item now, which is a verbal update on the work that's being done around pharmacy, optometry and dental services, and turn to my colleague Sarah Starbuck for an update on this. Sarah?
Thanks, Jerry. So just to update, this is in relation to the transfer of dental services, primary, secondary and community, pharmaceutical services and general ophthalmic services to the ICB with effect from 1st of April 2023. The ICB have been working closely with NHS England as commissioner for those services currently, to make sure we can safely transition services through to the ICBs with effect from 1st of April. The model we're working on is we have been working for quite some time with the other ICBs, the other systems within the East Midlands, and that's Lincolnshire, Nottinghamshire, Derbyshire, Leicestershire and Rutland and Northamptonshire, and we're working collectively in terms of the model we are putting in place, which allows us to manage the arrangements as resiliently as possible and support NHS England colleagues with this. NHS England will continue to support the arrangements, but it will be responsibility for the ICB in terms of delegated decision making for those services. It's very similar in terms of the arrangements that were put in place in previous years for general practice services. So the process as it stands, we have completed a pre-delegation assessment framework. So this is part of the national process of assurance to review the arrangements that the ICBs have in place to safely transition and take on those delegated arrangements from 1st of April. So the PDAF, as it's called, the Pre-Delegation Assessment Framework, is a response that reviews system level responses, risks and mitigations. So it's a full assessment of those services and the arrangements that were put in place. That's been through a panel, it's been through subject matter expert review panel, and the arrangements have now been formally signed off at region, and it went to a national moderation panel on the 12th of October. We're awaiting updates from that. However, currently Lincolnshire is on track in terms of the arrangements and working with the various work streams in terms of particularly quality and finance to make sure that we can safely transition the arrangements from 1st of April. Happy to take any questions in relation to the process.
Thank you very much indeed, Sarah. And just say that there's an engagement with the relevant representative bodies from these arrangements. Could you just say a few words around that, so the committee has assurance that the clinicians working in these areas are fully engaged in this work?
Of course. So Sarah J, you may want to come in terms of the 4 pillars of primary care, but I think it was just to, in terms of the local process we've put in place within Lincolnshire, as well as making sure we're working with the four contractor groups within primary care. And we have a primary care transition oversight group in place that meets monthly, which brings together the various work stream leads for this piece of work, but also brings together the 4 contractor groups. So it's not just dental, pharmaceutical and ophthalmic services bring together general practice are part of that conversation to make it a truly integrated approach in terms of the transitional arrangements. But I'll leave Sarah Jane to update in terms of the broader work.
Sarah Jane.
Yes, thank you. I'm Sarah Jane Mills. I'm the Director of Primary Care Communities and Social Value. So as Sarah's highlighted, we have been working for some time now with the 4 pillars, and they have been actively engaged in the planning for the changes. Alongside that, as part of the establishment of the Integrated Care Board, we have recently formed what will be described as the Primary Care Advisory Group. It may end up with a new name. People aren't completely committed to that at the moment, but ultimately this brings together leaders from across the different areas of primary care to support the strategic development of the fully integrated primary care service. So we have representation from the 4 clinical leads who have supported locality engagement, the chair of the Primary Care Network Alliance and the vice chair who are leading the development of primary care networks, and with that the development of population health management. Representatives from the local medical committee and local pharmacy committee and local optom committee and local dental committee. Myself as the Director of Primary Care and the ICB Medical Director, plus Jerry as Chair of the Primary Care Committee will be in attendance, and as an observer to make sure we're making the various connections. Increasingly that formal structure will ensure that all of our planning looks at the integrated offer, and that we really exploit the opportunities to improve services within local communities and across primary care generally.
Thank you very much indeed, Sarah-Jane. Thank you for that. I think it's probably okay for us to note the work that's being done to bring our pharmacy, optometry and dental colleagues alongside us. We've discussed before about the importance of integrating care and some of the concerns that do exist around some of the services which at the moment are commissioned and overseen by NHS England rather than ourselves. Locally, for example, some of the conversation we touched on before around dental services within the county. So it's good that we're continuing to make progress in that regard, both in terms of these powers being transferred to us, but also the engagement of the clinicians more locally in the work. So is there any are there any questions that colleagues want to raise regarding this piece of activity? No, if not, thank you very much indeed, Sarah. I'll move to item 10, which is an update on performance, and again, return to my colleague Nick Blake. Nick.
Thanks, Jerry. Yeah, in terms of the performance report, this gives an overview of the current metrics that we review within the Integrated Care Board Primary Care team and are reported through to the Primary Care Communities and Social Value Steering Group. Again, they are work in progress, and I'll pick that up as I go through the report. There are three main areas we're looking at currently, which are related to quality of care, access to primary care, GP services, and enhanced access appointments, and also management of long-term conditions. We are looking at further metrics, and again, they're further on in the report, just reviewing how useful those are. So in terms of quality, we are monitoring CQC ratings, so practices that are rated as inadequate and those that requires improvement. In terms of access, we're looking at the percentage of appointments where someone's seen by a GP, where those are face-to-face, how long they take to book, etc., but also the number of enhanced access appointments available and how those are used. In terms of quality, I won't go into that in detail because I appreciate that's coming further on in the agenda in terms of the specifics, but we have one practice rated as inadequate, which is Hawthorne Medical Practice, and then we have 4 rated as requires improvement. Obviously the OCB team, the quality teams are working with those practices, but again, I think that will be picked up further in the agenda. So moving on to access, we've got reasonably good performance in terms of access when we compare ourselves to regional and national averages. There's been a slight drop in July in terms of the percentage of appointments seen by a GP. It dropped by around 3% to the previous month, but we're seeing an increase in face-to-face appointments and reasonable times for booking of appointments. And again, good performance in terms of the amount of enhanced access appointments available, although some issues with utilisation of those. Now, moving on to long-term conditions, there's 5 key indicators we look at relating to health checks for people with a learning disability or a severe mental illness, and then some key long-term conditions are CVD, hypertension, so people with high blood pressure, diabetes and asthma. In terms of health checks, we have good performance, particularly in terms of LD health checks. CVD and hypertension, CVD and asthma, sorry, are reasonable. One of the areas that we are going to be focusing on and looking to improve performance on is diabetes and people accessing the 8 care processes. So these are the kind of checks that would happen in primary care for people with diabetes to make sure that their care needs are being met. And again, we'll be working with practices around that. Moving on to further developments in terms of the performance report. We are table 2 in the report shows some of the indicators we're looking at develop further. There's some discussions with our clinical leads around what's useful to look at, and there are some caveats. And picking up the data around access, GP access, there are some caveats around the consistency and usefulness of that data. So some of these metrics we'll be diving into in a bit more detail to understand better what they're telling us and whether they provide us with a useful indicator about how primary care is being delivered. These are being picked up through clinical leads and through the primary care communities and social value steering group, and will be developed further and linked to the programme as that developed, so that the report I presented previously. The final point from me is just to bring the committee's attention to Appendix 2, which is a PCN level primary care dashboard, which provides a wide range of data, which is pulled together by our business intelligence and performance team. This is available at practice level and is shared with clinical leads and GP practices in localities, and is reviewed by our primary care quality assurance and oversight group. So they will use this information to inform the discussion around practice quality and any delivery or risk issues. It's provided here to the committee as an example of the kind of data we're looking at and the kind of data we could develop further to inform the committee and allow the committee to carry out its assurance function in terms of primary care. I won't go through it line by line, there's a lot of data in there, but I'm very happy to take any questions or comments from the committee.
Thank you very much indeed, Nick. It's acknowledging it's very much work in progress at the moment, but there is a lot of information in there that we just need to be aware of how it gets unpicked and understood well. So, are there any questions from colleagues relating to the performance report? I think I would just add, Nick, and it's based on the conversation we just touched on with Sarah Starbuck, which is about bringing pharmacy, optometry and dental colleagues on board. There'll be no doubt a whole data sets associated with their access issues and their workload and so on, and just bearing in mind that whatever this one, which just looks at general practice, we'll have another load of data coming through as well. So I think that does, again, we need to be able to see the wood for the trees at this level, appreciating that there needs to be operational oversight of a vast amount of performance indicators, that this committee looks at the key performance indicators from an assurance purpose on behalf of the Integrated Care Board. So yeah, bearing in mind this data set could get bigger, we will need to think, as we are doing, carefully over the next period of time about how we segment this data set down to things which are relevant for relevant groups. But nonetheless, it's a really good start, and well, actually a continuation of work that's been underway for a while. Are there any other further questions for Nick relating to this report before we move to quality? No. In which case, thank you very much indeed, Nick, to you and colleagues. Now, if I might just pick up before we get to quality, just a verbal update, Sarah Jane, from yourself relating to the government's priorities, or what in shorthand terms known as the ABCD priorities.
Yes, thank you, Jerry. So as you've actually described, the current shorthand for the recent publication of the refreshed priorities for the NHS are known as the ABCD. The specific areas of focus for us as a primary care directorate are with regards to the expectations set out by the Secretary of State that indicate that anyone who needs a GP appointment should be able to access one within 2 weeks. We are currently, as a Lincolnshire community, aware that approximately 80% of appointments are provided within a 2-week period. So there is obviously some further work we will need to do to reach the 100% aspiration as outlined. that work will feature as part of our ongoing strategic development that looks at primary care access and increasingly how we better understand the nature of access by the individual groups of people living in our communities, and how we can make better use of the broader range of opportunities that there are now, and linking back to our previous conversation, particularly with respect to the additional services provided by community pharmacies, for example. So in that context, we are continuing to look at what is the current level of demand, and what is the nature of that demand, and then how we can start to close the gap in terms of the target. Within that, we are very mindful of the fact that there are different groups of people with very different needs, and what we are committed to doing is focusing on how we protect access for people who need continuity of care. And that might be patients with an ongoing long-term condition, who are particularly frail, or who are going through a complicated diagnostic process at any point in time, alongside those people who need episodic access for treatment of a minor illness. So a lot of work we need to do with regards to understanding that and making sure that the detail is there. One of the major areas of concern that people feedback almost consistently with regards challenge of accessing the practice by phone. The commitment through the Secretary of State is for us to strengthen the telephony infrastructure, which will ease some of the pressure, but that in itself won't resolve the problem. So alongside looking at how we develop our telephony infrastructure, we are looking at how we support better utilisation of digital routes, and again, what are the areas of demand that currently require patients to contact their GP practice by phone, and how we might develop services to support a reduced number of phone calls. For example, ordering your prescription online, which you can now do through the NHS app. And then finally, the great focus with regards to dental services across Lincolnshire. We are very aware that access to dentists are particularly challenging, and have already linked with colleagues in NHS England with regards to the dental strategy, which will be a feature of our work programme going forward. I probably don't want to go into much more detail, but you will see these areas incorporated in the performance report and the future programme development report that will come to PC3.
Thank you very much indeed, Sarah-Jane, and it no doubt reflects itself in the programme work streams that we heard about earlier from Nick. So thank you for that update. I'm assuming for the moment, given that the government has trailed the ABCD work now for some weeks, that there probably aren't any great questions from colleagues around that, but should there be, happy to take them. No. If not, thank you very much, Sarah-Jane. And finally, under item 12, this is an exception report. If there are any items that we need to be brought to our attention in relation to finance, Emma, should there be anything for us to be aware of?
Thank you, Jerry. No, there's no exceptional items to raise in relation to finance.
Thank you very much indeed, Emma. Thank you. So our last major section relates to quality. And we're joined by Martin Fahey. Welcome, Martin. If you could take us through the items 13 14 and 15, and we'll take each of those in turn. So thank you, Martin.
Thanks, Jerry. And for those who've not met me before, Martin Fahey, I'm the Director of Nursing and Quality in the ICB. Jerry, I have got 3 separate papers, item 13, 14 and 15. What I will do is I'll take item 13 first, which is the general update. But because we've got a separate paper today for Lakeside and Hawthorne, I won't cover them off in this paper, if you like, item 13, which is the general quality update report. So with that in mind, and I'll take it that colleagues have read the paper in advance. The first part of the paper gives a detailed overview of where we are with Lakeside, Stamford and Hawthorne, but because I'm going to talk about those separately in a little bit more detail in the next 2 reports, I'll wait till then if colleagues are okay with that. So that will make this report relatively quite short. There are 3 other practices to note that are at overall required improvement with the CQC, and of those 3, that is Morisco, Braunston and the Spalding practice, as previously reported in the committee. I'm pleased to say that Morisco has had a recent re-inspection, although we're waiting for the final publication of the CQC report, but the indicative early findings of the report are very positive around that. So we have a good level of confidence that Morisco will be in a position to report some good news in that respect and hopefully move out of requires improvement. But as I said, we're still awaiting the final publication of that report. And the other report to note from a Care Quality Commission point of view, CQC, is Merton Lodge Surgery. Their report was published on the 13th of September. And I'm pleased to say that the practice is rated as overall good across all 5 domains. So really pleased to be in a position to report that. Jerry, that's it in respect to the item 13. I'll pause there just in case there is any questions. But like I said, I will go into the detail now of the Lakeside and the Hawthorne papers.
Yeah, okay. Thank you, Martin. So are there any questions on that introduction to the quality report, accepting that we're going to deal with Hawthorne and Lakeside separately? No. In which case, Martin, feel free to move us on to Lakeside.
Thank you, Jerry. I'm just waiting for me to go live. Usually people can still hear me, but I'll just wait for the red box to flip over. Thank you. I'm live again. So this is a more detailed report in relation to Lakeside Medical Practice. The paper is, I think, very helpfully, because we have reported on Lakeside on a number of occasions previously. But what this paper does is goes into a little bit more in depth as to where we've been and in some cases the journey since the initial inspection of the CQC, which was in June 2021. I won't necessarily pull out line by line detail of the report because the report speaks for itself, but suffice to say, the initial inspection was, as I just said, in June 2021. The subsequent published report on the CQC website was published on the 2nd of August 21. It's not unusual that there's a time delay between the initial inspection and the report finding its way into the public domain. At the time, the practice was rated as overall inadequate, and it was inadequate in 5 out of the 6 quality domains that the CQC used to carry out its inspection. There was a re-inspection a couple of months later in September 21. And again, I won't go into all the details, but the practice had made some progress at that time, but nonetheless, there was still some significant challenge that still had to be redressed on the back of that inspection. Our colleagues in Health Watch worked with Lakeside at the time and on behalf of the CQC, and they carried out quite a considerable patient survey. The details in the report, but there was over 1,450 respondents to that. So that's a sizable number of people who had accessed that service, and Stamford folk who'd taken the time to feed that feedback back to our colleagues in Health Watch. And the outcome of that was there was many significant challenges and issues raised as part of that process in respect to responses about the standard of service being provided by the practice at the time. Subsequent to that, you'll see the details of ongoing visits in February and March and conversations with the CQC, and indeed support from the ICB quality team, clinical leads, and indeed the LMC have been there in a supporting capacity all the way through. There was another re-inspection which was published, it carried out in or got conducted even on the 1st of June 2022 this year. But it was published in March 22. Won't list out all the details, but there was considered progress. The overall rating requires improvement at that time, which, just to remind people from when I started my report, they were initially inadequate. So that is progress. But still, there was a number of areas that were still remaining, particularly around some of the issues around governance and some of the issues around appropriate and safe use of medicines, including medicines optimization and some of the oversight and governance process in place with respect to prescribing. The CQC then placed additional measures on the practice for a further 6 months, which probably brings us up to date. I'm hoping colleagues find this helpful, because it's quite important that we just see the journey the practice has been on and the continued support that's been provided to them by the system, the ICB, the CQC, and indeed the LMC. To bring colleagues up to date as to where it currently stands now, as of September 22, I'm pleased to say that the CQC has now withdrawn its most recent notice of proposal as it's described, which means that the surgery is no longer in special measures. Our chief pharmacist, recently appointed to the ICB, has gone out only on the 22nd of September and looked again at the governance and oversight, and particularly the dispensary arrangements in place within the practice. And I'm pleased to say that they've noticed there's continued good progress and no significant areas of concerns were flagged in that meeting. Sarah Jane, who's our ICB Director for Primary Care, Communities and Social Values, has met with the new Chief Executive of Lakeside, and I'm pleased to say there's a good emerging relationship there and a continued commitment by the practice to bring forward the improvements and obviously to embed the learning and ensure that they continue to deliver. So I'm going to pause there, Jerry, in case there's any questions, but it's been quite a long process with Lakeside, but I am pleased to say that the practice has made some and covered some really good ground towards improvement. So I'll pause there in case there's any questions or points of clarification.
Thank you very much indeed, Martin. Do we have a sense of when the CQC may visit Lakeside again for a re-inspection?
To directly answer it, normally within 6 to 12 months, Jerry, but we don't, and for obvious reasons, they wouldn't necessarily give advance notice of that, but that's what we would usually expect within a 6 to 12 month period. We will continue to do the ICB quality and oversight visits, so we've scheduled those in and we'll continue to do it. So in that sense, the level of surveillance from the ICB will continue. And also we'll obviously work closely with Health Watch colleagues and with the practice should there be other concerns that might come to light. And obviously we'd be keen to be on the front foot and react to those should they surface.
Thank you very much, Martin. Are there any questions from colleagues around Lakeside? But the report again is very comprehensive in its detail. No. Thank you very much, Martin. In which case, shall we move on to Hawthorne?
Thanks, Jerry. This is agenda item number 15, colleagues. It's a detailed report on the recent inspection which was carried out by the Care Quality Commission, the CQC, into Hawthorne Medical Practice, which is in Skegness, and the visit was carried out on the 23rd of August. There's a lot of very detailed information contained within the papers, and I would very much so want to kind of encourage members of PC3 to take the time, and I'm sure you have, but to read the CQC reports. The links are within the report because the detail is published now on the public facing website, so you can read the detail. I think it's quite important that we take time to do that and reflect on some of the content. By way of giving colleagues an update as to what's contained within the report, the summary of the findings are quite challenging. The practice has a number of areas of significant challenge, some of them being, I'll pick out a few. The CQC found that there was not safe and effective oversight of the dispensary services. Patients did not always receive effective care and treatment that met their needs. The practices had not taken reasonable steps to protect patients and others from issues posed by healthcare associated infections. So that's infection control. There was issues with cleanliness. There was issues with some of the furniture within the surgery. There was issues with some of the due tension and processes placed with managing infection control processes within the surgery. So some significant areas and issues around governance systems that were proven at the time to be ineffective. Issues with staff not always receiving the appropriate training and supervision and appraisal. So very clear areas of challenge in that respect for Hawthorn practice. The latter part of the report goes into the detail of the support package that we've rapidly put in place alongside obviously the LMC, but indeed our clinical leads and quality leads within the ICB. And I won't list them all out, but it's quite clear from the detail with the chief pharmacist, the clinical lead, support by the nearby neighbouring coastal practices to step in and support. You've had a similar journey with the CQC, and keen that we replicate good learning and practice in that respect where we have got challenge practice. I would want people to understand at this stage it's supportive offer. It's about working with that practice. The practice is very receptive to the input, both externally and indeed to the feedback it's had from the CQC. So I've got good confidence that we'll work quickly and rapidly to bring forward that recovery programme. But the reality where we are is that the service was rated inadequate. I didn't actually clearly state that at the start of the report, Jerry, and I needed to do that. So it is a significant challenge to find yourself in a position where we have got that CQC rating. I would pause there because I think many colleagues at PC3 are familiar in some ways that when we do find ourselves in this position, we have got a very robust and clear approach with practices, and thankfully we do have a readied available support and recovery programme that we can put in place rapidly with the practice. So I would want to assure members of PC3 and indeed the public that we are satisfied that the practice is safe and that the service currently available to patients is just that. But there is some challenge and we will be working quickly with them to make sure we bring forward those improvements. Again, I'll pause there for any points of clarification or any questions colleague would like to ask. Thank you, Jerry.
Thank you very much indeed, Martin. Again, are there any questions relating to the CQC report, Martin's update of the support that we're providing to Hawthorn to help them move from inadequate? I suppose amongst all of this, Martin, one of the things that stood out for me, and well, it was amongst many things, is that there was no patient participation group in the practice because according to the CQC, this practice stated there was no interest from patients. I appreciate sometimes it can be difficult to do this, but a vibrant patient participation group will always bring the best out of a practice. All consumer groups always bring out the best in the organisation that they consume the services of. So support the work around establishing a really vibrant PPG for the practice will be part of sustaining them into the future with the care that the practice can deliver. And I think we've all experienced really good patient participation groups helping practices work through some of the issues and bringing to their attention some things that are both complicated but sometimes very easy to resolve. So it just struck me that that was a strange thing, that no interest from patients, and just thought, well, I'm surprised. I'd be surprised that there's no interest from patients. But a practice that doesn't encourage its patients to join in also is a practice that will always potentially run into difficulties regarding the services it provides. So let's watch the work that Hawthorn are doing with your team's support. And hopefully our expectation is we'll see progress made as we have done with other practices over the past period. Are there any final observations relating to the CQC report? Okay, no, thank you. Thanks very much indeed, Martin, for your 3 items. Nick, we've got the risk register paper. You want to particularly mention a new risk on there relating to asylum seekers?
Yes, thank you, Jerry. We'll just wait for the box to change out of the way. Thank you. So yeah, there's a number of new risks on the risk log to note, and one I'd like to pick up in a little bit more detail. I won't go through all of the new risks line by line. I assume that people at the committee's read the paper, but the new risks in particular relate to APMS contracts and the impact on pensions for primary care staff employed by federations. We also have risks that relate to pressures within the health system. So pressures, risk number 18 related to paediatric referrals, but also 22 in terms of secondary care referrals. So this is where GPs are referring people through to secondary care services, and some of the issues around long waits. We have an issue around data sharing, so that's really around primary GP practices signing up to data sharing agreements to support data flows that will underpin work around population health management and integrated care. And then the risk around energy costs, number 21, so that's really just around the impact of the rising energy costs on GP practice finances and resilience. The one I wanted to pick up is risk number 23, which relates to asylum seekers and refugees. There are a number of asylum seekers and people being placed under the Afghan Resettlement and Assistance Programme into Lincolnshire, and of course this is important work and supporting these vulnerable people, but it is having a knock-on impact onto primary care services and associated services, so things like health visiting services, maternity services, and wider community services. The resettlement and the accommodation of people within Lincolnshire is outside of the ICB's control, and we get very short notice on when accommodation has been set up for these groups of people. They sometimes have complex health needs, which requires coordination across a range of services, and primary care is central to that. So there is some funding available for some patient groups for primary care, but other patient groups are unfunded. So there is a general knock-on impact in terms of primary care capacity and short timeframes to stand up services to review patients, find out what the health needs are, and then put care in place for them. So really just to flag that to the committee's attention. There's ongoing discussions within the system across a range of stakeholders and up to the resettlement and asylum programmes as well, just to make them aware of the impact on primary care, and we're working directly with the affected practices to support them. But happy to take any questions or comments from the committee.
Thank you very much indeed, Nick. Again, any questions from colleagues relating to the risks? Can I just clarify under paediatrics, Nick? Are these general paediatric referrals or are these specialist paediatric referrals?
There are issues. There are some issues generally, but these tend to be around referrals for autism or ADHD diagnosis and referrals into community paediatricians, where the main issue is.
Right, thank you very much indeed, thank you. Okay, so can we note the risk register as it stands and the new risks that have been brought onto it? In terms of completing today's agenda, I've identified a couple of items just to bring to the attention of the board from our meeting in public. One is the work around sidings and spalding practices, and the second one is, because it's not been reported for me, just to note to the board the work and CQC report on Hawthorne. Are colleagues happy with those as items to be brought just to the attention of the board? Okay, thank you very much. In which case our next meeting is in public, will take place on Wednesday the 21st of December at approximately 11:15. can I thank colleagues' contribution today, particularly in terms of the papers for today's meeting. Look forward to seeing colleagues again at future meetings. So in which case I'll draw today's meeting to a close. Thank you very much indeed. Thank you.
Thank you.